is Chalazion. Retained lipid secretions are causing aggregation of certain cells, causing this granulomatous inflammation. And it is sterile inflammation as there are no microorganisms causing infection.
Clamp is applied. It is tightened and the eyelid is everted. The Chalazion is then opened up from its posterior aspect using a number 11 blade. Once the Chalazion has been opened, a curette is then used to clear out its contents. A vigorous curetting of the contents of the Chalazion will help facilitate the drainage. Often the granulomatous material requires quite a vigorous action to completely deflate and clear the Chalazion. In this phase of the procedure, I'll often tighten the Chalazion clamp, as often it becomes loose as the Chalazion itself deflates. Again, expression of the granulomatous material within the Chalazion is aided by the use of a curette. The Chalazion clamp has moved inferiorly in this case, but it is still in an adequate position to proceed with the remainder of the procedure. I would generally perform a small biopsy taking part of the posterior wall of the tarsal plate. I routinely perform a biopsy of the posterior aspect of the tarsal plate, removing a rectangular piece of tissue with Westcott scissors as demonstrated here. The specimen is then submitted to pathology. An inspection is made for bleeders. There are none in this particular instance. The Chalazion clamp is removed. I then generally apply Tobradex ointment to the inferior fornix and then apply a pressure dressing, which I have the patient keep on until the following morning. I will often have them apply ice over the patch off and on during the day. Chalazions are quite common, so it is important to have an effective method for incision and drainage, which ensures patient comfort and an adequate drainage of the Chalazion itself.